talk about adaptive strategies to improve cognitive assessment and promote really timely diagnosis and optimized care in Alzheimer's disease. I'm Alireza Atri. I'm a cognitive neurologist. I direct the Banner Sun Health Research Institute in Sun City, Arizona, and I take care of patients and families with Alzheimer's disease and related disorders. As a subspecialist, I've been doing this for over 20-something years, and I'm really involved in best group practices and education. And I know that ultimately the front lines revolve around primary care and family practice. And so it's really exciting to be able to bring this educational opportunity to you. This is supported through a independent educational grant by Genentech. They are not involved in developing this material. This has all been under my guidance, and my disclosures are also on the website. I am involved in Alzheimer's disease clinical trials, educational grants, and research through multiple mechanisms, including NIH and also companies. I always start the talk with this quote regarding human beings are members of a whole in creation of one essence and soul. If one member is afflicted with pain, other members uneasy will remain. If you have no sympathy for human pain, the name of human you cannot retain. This is as true now as it was in ancient Iran, Persia, about 850 years ago. And the fact is that we're going to talk about abnormal proteins that become toxic as we through a disease process and accumulate and cause damage, and PET scans, and maybe even p-values that have to be met for certain things. But ultimately, it's not about that. It's about people, and this is a disease and a condition that affects the person that's at the center of it, but also a whole community around them. And I think hopefully by the end of this talk, you'll be convinced that there are things we can do, and that we're really at a juncture where the science will be catching up over the next 10, 15 years to provide us better ways to diagnose individuals, and also that will emerge into therapies. But ultimately, we need to be able to care for them. And the first step is to recognize there's an issue and take it from there. So here are some fundamental facts about AD. Bottom line is Alzheimer's disease and related dementias are really highly prevalent, and they often occur late in life. One thing that I think it's important to appreciate is that these are incurable neurodegenerative diseases. They're not something benign. They're not part of normal aging. And as such, we really, it's important for us to be able to provide, accurate diagnosis for individuals. What we appreciate now is that diseases like Alzheimer's disease are caused by misfolded proteins that become toxic. And as they accumulate, there's a mechanism that involves neuroinflammation that then ultimately leads to cellular disruption, injury, and death. And that actually AD can now be accurately diagnosed during life and meaningfully managed. AD cannot be cured, but this is no reason not to diagnose it in a timely way, to provide the multifactorial care that's needed for individuals so they can be on a better trajectory. And the prevalence of AD and ADRD are greatly increasing because of the population is aging. One important thing is not to confound something that is common with something that's normal. So, even though there is a process of aging, a normal aging that can affect cognitive functions, we don't sort of turn around and say to somebody who comes to us with chest pain and say, oh my goodness, you're just getting old. We don't do that. And I think it's really, really important not to take symptoms that may be concerning, both for either for the patient or for a care partner, or even for you as a clinician, um, is to be able to take those symptoms seriously and to go down a pathway of evaluation and not to ascribe them to quote unquote, this is normal aging. Unfortunately, the data shows that many healthcare providers around the world think that dementia is a part of normal aging. And what I'm here to say is that the data suggests otherwise, that we can actually do that this is caused by diseases and conditions that may be prevalent as we age, and many of them obviously can be managed just like Alzheimer's disease, but not cured yet. And we know that the majority of primary care clinicians feel like they need to be more confident about their both the diagnosis and management skills and need more guidance and resources. And hopefully, again, by the end of this talk, you'll agree that the timely, accurate, and appropriate diagnosis, disclosure, and treatment are really medical, ethical, social, and economic imperatives. And it does matter, and why it matters to make an accurate diagnosis and come up with a good treatment plan. And you know, I'll explain during this process that AD, it is very complex and it's dynamic, and it occurs over decades and has a long sort of clinically quiescent phase while the disease is percolating in the brain, and can also result in heterogeneous presentations. So with that, what I could say is that the contributors and causes of these conditions, again, seem to be a vicious cycle that starts with abnormal and toxic protein fragments that accumulate, ultimately leading to neuroinflammation, mitochondrial lysosomal damage, and a final pathway that involves cellular energy dysregulation, oxidative stress, and leading to basically a neurodegeneration, destroying of synapses and neurons, and ultimately affecting network function, which then affects some aspect of cognition, function, or behavior. The causes may be very different. If someone's in their 40s or 50s, and individuals do have Alzheimer's disease at these stages sometimes, they're very rare. They're oftentimes caused by dominant mutations. They may have only really the Alzheimer's pathology, but individuals who really make it into their 70s and 80s, the data shows that as we're accumulating one type of damage from Alzheimer's disease, we're accumulating other type of damage from cerebrovascular disease. And even one neurodegenerative condition like Alzheimer's disease ultimately leads to us having neuropathological changes in the brain that are due to several. One of the major advances in the field has been to take what we used to call Alzheimer's disease years ago. People thought about Alzheimer's disease as Alzheimer's dementia, and they thought about sort of like the syndrome. What we've done now is separate the biology, the disease, from the clinical manifestations and the illness, the syndrome. I'll explain that more in detail. But it turns out that as we do that, and now we have biomarkers that allow us to actually measure some of these biological, pathobiological mechanisms related to AD during life. So we don't have to wait until someone dies to get their brain. Before that, through spinal fluid, PET scans, and eventually come into clinic over the next several years, but they need to be validated, are going to be blood biomarkers that show the disease in the brain. Again, the disease is different from the clinical manifestations. And as we've entered a new era of these biomarkers, this is going to really help us in many ways, both on the experimental side for clinical trials to get to pick the right patients and design the right therapies for them at the right doses, but also to target the underlying biology and bring these emerging therapeutics into the clinic. All right, so I'm going to show you a lot of slides. I'm not going to spend many minutes on some of them. You can go back, but I wanted to make sure they were there. So in some ways, this is going to be like drinking water from a fire hose at times. So try not to read everything on a slide, But if you want to go back, I wanted it to be there so you can rewind and take a look at it. So what's happening? What's the challenge of our generation? Really, the challenge is that no matter where you're sitting and what continent, the numbers over the next 20 to 30 years show that we're going to have really a tsunami of cognitive impairment of dementia due to neurodegenerative conditions. And the numbers are going to basically triple, or double or triple. And no one's figured out how to solve this. It's not because, there's a special diet that's going to eliminate everything, or, one magic ingredient. This is going to require a concerted effort on all our parts. Here's a far side that say, Bob, what's a mountain goat doing way up here in a cloud bag? Well, when they crash, unfortunately, it's not just going to be the goat that's going to get hurt, and the pilots are really at risk. And it turns out the global impact of Alzheimer's disease and related dementias is very, very large. If you look at the numbers of leading causes of mortality in the US, and this is actually before COVID. COVID has now joined this list. But everything that was in the top 6 was going down quite a bit. HIV, heart disease, breast cancer, prostate cancer, strokes. What was really, really going up was Alzheimer's disease related dementias. And between 2000 and 2017, really deaths from heart disease have decreased 9%, whereas for AD, they've gone up about almost 150%. And that's including the fact that in death certificates, AD gets undercoded because individual may actually, because of the last stages of the disease, die from a pneumonia or an infection, but may not be actually, Alzheimer's disease may not be listed as the primary cause that really got them to that state. This is something that's surprising to many, that Alzheimer's disease actually kills more individuals than breast cancer and prostate cancer combined. And another something that's surprising to individuals is that there are several 100,000 individuals in the US that have actually early onset Alzheimer's disease. We define that just arbitrarily by age less than 65. But if we think about currently about almost 6 million or so individuals, several 100,000 actually have Alzheimer's disease symptomatically under the age of 65. This quote, "No person is an island, entire of itself. Any person's death diminishes me because I'm involved in mankind, and therefore never send to know for whom the bell tolls, it tolls for thee." This really resonates with me, resonated for me from the time that I was young, and this was on my one of the quotes in my PhD dissertation. But if you think about any person that's involved, if 1 out of 3 seniors will die of Alzheimer's disease or related dementia, there's going to be people around for every person who's affected, on average 3 to 4 people who are going to be providing their care. So when you see somebody like this who goes into their twilight of their life, oftentimes they may be surrounded by family, maybe young kids and others. And in this case, this is my father. And it turns out in my family, on my mom's side, my aunt, who was like a mother to me, developed dementia, and we took care of her. And later on my dad's side, unfortunately, there's a history of late onset, and my dad developed this, and we took care of him for over a decade. And so I can tell you, both from 20-something years of just taking care of patients and families with Alzheimer's and related conditions, and also from my personal experiences, this is something that none of us are going to escape. And it requires really a collective, it's a collective global issue that's not going to be solved by National Institute of Health, by the government, by pharma. It's going to require our collective effort for all of us. And obviously you're watching this program, so you're interested. So I thank you for doing that, and for continuing to put this as one of our major challenges facing vulnerable individuals. And at some point, that individual may be you, whether you're at this side of the table or the other. So kind of going back to our current understanding of Alzheimer's disease and the pathobiology. So obviously, by the time we get people and get their brain and it's markedly atrophied with lots of neurodegeneration, a lot has occurred. And what we understand, by definition, Alzheimer's disease is still defined by plaques and tangles. Amyloid plaques made of beta amyloid peptide, and ultimately causing neurofibrillary tangles caused by hypophosphorylated tau protein. The tangles are intracellular, the plaques are extracellular, but actually the process by which these come about takes about 20 or more years. So the amyloid can be processed into smaller bits that stick together, but they're still soluble. Ultimately, they form what we call protofibrils, and then ultimately fibrils, and they deposit into these plaques. And as they're doing that, they're causing damage by starting an inflammatory cascade. And in some cases, maybe that's going to be protective, but in many cases, ultimately, it becomes a runaway process. And as these tangles also develop, they can seed from neuron to neuron and cause neurodegeneration, not just in the neuron that was affected, but to the connected neurons. So it becomes, to me, almost like an analogy where for maybe a decade or two, you have toxic kindling. And this is really the amyloid, sticky amyloid, and the plaques coming together. And this toxic kindling ultimately leads to a spark. And the spark really is the tangles. As we age, there's some other mechanisms that involve producing tangles in the medial temporal lobe. And really, it's amyloid is almost like an accelerant for this fire. So once that occurs and amyloid is around, you can get the spread of fire through both the tangles and through neuroinflammation. And you can see that if we don't get this early enough, then maybe we can mitigate sort of a little bit the tempo of the fire, but we're not going to put it out. And to illustrate that is really the downstream effects of amyloid and tangles, is that not only does it affect the cells themselves, but it involves vascular dysregulation, so the blood-brain barrier becomes disrupted. As I mentioned, neuroinflammation in multiple ways, and there's toxicity that occurs through calcium, through energy dysregulation, through difficulty breaking down other types of proteins through lysosomes. So once you accumulate, again, Alzheimer's pathology, you're more likely to then develop and accumulate other types of pathology, including alpha-synuclein, which is involved in the protein involved in Parkinson's disease and Lewy body disease, which is a spectrum. And what we're understanding more, this other types of proteins called TDP-43, ultimately causing neurodegeneration. So what are the long-established risk factors for dementia, not just Alzheimer's, but dementia? We're certainly, age and sex are two. These are non-modifiable. We may want to sort of fib about our age, but age still is a strong risk factor because this is oftentimes can be an age-related disease. Women, for some reason, develop dementia more than men. Life expectancy plays some role in that, but not all. We also know, because of both probably multiple genetic factors, but also social determinants of health, different ethnicities are more at risk. Oftentimes they have also comorbidities involved with multiple other conditions like diabetes or high blood pressure or cholesterol that we absolutely know are toxic to blood vessels in the heart and therefore to the brain. The genetics is less well understood. Again, there are probably at least 20, 30, or 40 genes that increase your risk of developing Alzheimer's disease a little bit, and some that actually are protective. A risk gene, one of the major ones is ApoE4, which is a cholesterol transport protein. Again, individuals who have this aren't determined to get Alzheimer's disease, but their risk may be higher, depending on whether they have one copy or two. But very rarely, people have mutations that cause early onset. And most people with early onset actually do not have these mutations. So we don't know for them what are the multiple factors that may be involved. As I mentioned, medical conditions is another. That's the bad news. The good news is that if you look at the Lancet Commission great report, talked about potentially modifiable risk factors to dementia along the sort of a life course pathway. And many of these are actually modifiable. And depending on when you modify them, you may have more impact than other times, including education in early life, hypertension, hearing impairment, even when mitigated later on, smoking, obesity, depression, physical inactivity, diabetes, low social contact. And recently added in 2020 are excessive alcohol consumption, head injury, and air pollution. And the thought is, as a population level, this can actually mitigate up to about 40% of the risk associated with later life dementia. It's not going to take it away, but could actually maybe delay the onset of the impact of diseases and conditions in the brain. And here again, I'm not going to belabor this. I'll leave it for you to come back to, are ways in some ways that one can modify this. And I would say the two things that are really, really important are exercise, I think, and sleep. And people ask about diet all the time. Well, what do you do? Do something that's balanced. That's really probably the most important thing. The greatest evidence is for the Mayan diet, which is a combination of the Mediterranean diet and the antihypertensive diet. All right. So what are the what is dementia? Obviously, and dementia is a condition. It's not a disease. And the core criteria is basically with neurodegenerative dementia, something you're not born with. You acquired it. It's something that ultimately some process or behavior or disease has caused a problem in cognition or behavior. That's neuropsychiatric functions like mood, anxiety, personality changes, etc., that ultimately at the dementia threshold is starting to interfere with independent function. Okay, so if you hit the threshold of dementia, it means that function is being affected to a certain degree. It requires a decline from a previous level, and you're not going to say somebody's demented if they're in the throes of a major delirium. They come to the hospital and they're septic or have a pneumonia. But of course, that's a stress test that makes you think that when they're out and things have settled, you want to assess their cognition. So again, dementia being a catch-all term for a condition that hits this type of threshold. But nobody wakes up one morning and says, gosh, today I'm demented. Yesterday I had mild impairment. So this is something that really is a slow change. So how do you think about cognitive impairments? Well, it's detected through a combination of, again, you have to talk to people and see where they were and what level of functioning and cognition they had before. So you may get information from them, but it's also really important if you are considering this as or suspecting this, to get information from someone who's knowledgeable, because the patient themselves may not be aware to the magnitude and effect of the changes that are experiencing. Ultimately, you also want to add an objective kind of assessment to that, something that you're proficient at, something that's standardized and validated. And if that's not sufficient, then you may refer to a specialist. And I would say neuropsychological evaluation would be also something that is important if it's not clear cut to you what's going on. For Alzheimer's disease, again, this has to be something that's insidious. It didn't happen overnight. Even when people come to you and say, "Gosh, well, I was totally fine before my heart surgery." Guess what? They may not. They may have had small symptoms, and it turns out the inflammation related to the surgery may have really decompensated what was going on in the brain, and they showed more symptoms. But generally, this is not this is something that you can look back, and if you really dig, you can find symptoms all along. They may be subtle, and they may be exacerbated in the setting of infection, illness, surgery, etc. And ultimately, it's something that doesn't happen over days. It's usually weeks to months, and will get worse. Now, with Alzheimer's disease, people always think memory, memory, memory. But even though memory is very important, it's not the only type of presentation. And it may be very, very common for many people, particularly as they're older. And again, this is an impairment not of well-established memories like 30 or 40 or 50 years ago, or being able to recite things, or language. This is more difficulty with learning and remembering new information, where they put things, details of conversations, repeating conversations. But a language presentation with word finding and other things that we'll go into is also very, very common. Visual spatial presentations are not uncommon either, particularly when individuals are younger, where they may have difficulty seeing things that are in front of them, judging lines or distances. And really, I would say executive dysfunction is just as important, and it happens quite early in many people. And this is impaired reasoning, judgment, problem solving, becoming really less efficient in doing things and having more mental things requiring more mental effort. And it turns out executive function really goes along with ADLs too. So and so that's a really important presentation. Okay, so why should we diagnose people? Why is it important? Well, here's the cartoon here. Say, wait just a dang minute here, we forgot to count. So obviously it could affect how people behave and have major consequences in people's lives. But ultimately, timely detection allows a number of things that are really, really crucial and are supported by the principles of ethics in medicine. It allows people to be at the height of their capacities, make their decisions better, for them to receive knowledge and education about the condition, appreciate how it may affect them, and make decisions about care planning, about how to minimize harm for themselves, about their future care, and to participate really in their own care, and also the better fulfillment of their desires. And in some cases, actually involves becoming involved in research. It also allows people to establish practical and healthy habits early, and shore up existing abilities before they're lost. That's really, really an important point, because once a ability is lost, it is difficult to regain that ability. And shoring up some of those support systems and compensatory abilities actually can allow people to function at much higher levels for much longer. Of course, it allows for initiation of multimodal interventions and treatments, including for their medical conditions, and also for Alzheimer's disease. And some of that actually is to take away bad medications. So that's an important thing. And undetected cognitive impairment dementia results in really inefficient, unnecessary care at higher costs, and produces harm to individuals. So if you were to look back at in your practice and think about individuals, let's say 70 or 75 years or older, and look at those folks who are probably responsible for, take the top 15% of folks who are potentially responsible for about 80% of your efforts and work. I bet that about half of those, there's some issue with cognitive impairment. Individuals don't wake up one day and, having had well-controlled diabetes, hypertension, heart failure, and suddenly have all those things go out of whack. And if individuals end up repeatedly in the hospital, in the ED, having these issues, then that's really a warning sign that they really may not be able to manage. So nothing's really truly changed about their medical condition. It's their ability to actually manage those conditions themselves, which is very, very common, even though individual can sit in front of you and have really good language function and have really good social skills, so that they can answer your questions, but potentially distract you, and You may ask them, are you taking your meds? They say yes. But part of that is trust and verify, because that's a major issue, I think, that we see. So let's talk a little bit about how the disease itself has been kind of pulled apart from the clinical impact of the disease. Because again, we understand because of resiliency and vulnerability factors, some people can harbor disease at a certain level and get away with it. Clinically, they can actually compensate for it better, and others can't. We don't understand why. So it's important to in some ways think about, the disease versus the brain failure, which is sort of the dementia. So through a biological definition, what's happened, again, this is the first cut and the first attempt, and this will really evolve over time. What's happened is that we've broken down the disease into amyloid, tau, and neurodegeneration for now. We understand that there's much more to it. And for simplicity, it's been made such that these are categorical, just binary, yes or no, even though in life many things are not binary. So as far as the amyloid goes, the idea is that you can be amyloid positive or negative. And this process, again, starts many years before people show symptoms. And during life now, through biomarkers, we can measure that through an amyloid PET scan. We have multiple of those, or through actually spinal fluid, which is a standard of care in Europe. And actually for many of us, of us specialists, we do lumbar punctures. And this is something that actually is pretty well tolerated and relatively easy to obtain. So they can be kind of categorized into amyloid positive or negative. And then later on, really tau. So is there aggregated forms of tau neurofibrillary tangles, which are associated, again, with Alzheimer's disease? You can measure that, again, with tau PET scans or through spinal fluid. And the neurodegeneration, there's multiple ways we can sort of have markers for that. One is through patterns of atrophy in MRI. One is through the glucose FDG PET, because ultimately that's looking at changes in metabolism that are related to basically synaptic networks and functions, and also the levels of total tau. So an individual could actually be be amyloid positive and tau positive, and not have symptoms. And that's actually a case for many, many years before people ultimately develop more neurodegeneration and symptoms. And this is sort of here kind of to depict that if you're amyloid positive, then you're considered in the Alzheimer's pathway. If you're amyloid and tau positive, then you have the biological disease. Again, it doesn't say anything about what's going on as far as your clinical capacity. If you're amyloid positive or tau positive, or in the pathway, then what we used to call Alzheimer's disease, which is really the dementia stages of Alzheimer's, is characterized by these stages 4, 5, and 6, where there's dementia, where someone does something bad with function, for example, is not completely independent. But this stage 3 is a stage that we also call mild cognitive impairment, where individuals, usually for many years, if we test them, they may actually have subjective cognitive changes. Someone may have noticed them, they themselves, but objectively, for where they are for their age, education, etc., they would be scoring much lower than they should be. However, essentially, their activities of daily living are preserved because they're generally compensating. These are called, so if you think about a line here, stage 3, 4, and 5 are really clinical stages. And stage 1 and 2 are what we call kind of preclinical stages, where the diseases, the markers of disease are available. In stage 1, really we can't find anything objective or subjective wrong. But in stage two, many people could actually say, you know what, subjectively, I think there's a change. Or very, very subtle objective kind of testing, with very sensitive tests can suggest slightly lower scores, but maybe not up towards the impaired range. So this is how we're trying to separate sort of the disease from the impact of the disease on clinical function. So in the past, when people were diagnosed, they were diagnosed at this stage. And if you think about the stages they may go through here, whether we call it preclinical MCI or dementia, or stages 1, 2, again, 3 should be here, 4, 5, and 6, biomarkers become abnormal much earlier. So amyloid gets deposited and can be seen through PET scans. Tangles are also manifest before people show symptoms, and ultimately there's neurodegeneration that can be seen. What about management? Well, we're focusing a lot more here on evaluation and detection, but as far as multifactorial management, what I would say is it's almost like the different parts of a chair. You need all these parts for the chair to be functional. And I think about detection, diagnosis, and disclosure, timely detection, and appropriate disclosure as really imperative, because basically delayed diagnosis and disclosure is justice and care denied, and it's harmful. And you can't give people care in a patient-centered way until you actually have this accurate diagnosis. Management is a combination of really non-pharmacological support through psychoeducation, kind of behavioral, lifestyle, changing their environment, nutrition, and pharmacological. So there's AD-approved medications. And ultimately, everything has to happen in a patient-centered alliance that happens in a triadic way, with a dyad that is the patient and a care partner, who eventually may become a caregiver, and you and your team, your clinical team. And I can tell you that providing this care really is meaningful and beneficial to patients, and can really change their life. And ultimately, you need all the legs of this chair together to be able to give it. So when you again think about the paradigm, and again, this is a caricature, without treatment, people will decline. And this decline isn't linear. It's for any given person, it's sort of up and down. But the goal really with treatments now is to put them on a different trajectory. So you get this benefit between the curve. And there's a ton of data to show that when you do this wraparound care with the psychoeducation, the medicines, you can on average put people on a better pathway. But ultimately, it's an incurable disease. So what you end up doing is really expanding the, depending on when you get the patients, that mild to moderate stages of the disease, and try to minimize those last stages where people need more care. But ultimately, the management paradigm needs to be personalized and is multifactorial. And one of them, again, is to make sure to avoid harm, provide benefit autonomy, and to mitigate this clinical progression. People don't come to you and say, gosh, I wish I could, spell world backwards. Basically, they're interested in maximizing their quality of life and retaining personhood for longer. And this is a longer conversation, but this is something that is meaningful and can happen if patients are diagnosed appropriately and given the multifactorial treatments. So the elements of evaluation are multifold. The first part really is to set the stage and figure out the establishment of shared goals in a patient-centered way. And as I mentioned too, it involves also getting information from a care partner. But what needs to tip you off is that if there's a concern from a patient, from a care partner that you could take information from, or yourself, if you're seeing they're not managing well, there's something that's off, um, then you can start the conversation about an evaluation. And as you know, you have to get information in your own way that you're proficient, but ultimately review aspects of cognitive function. And I'll go through some of the areas of that, of how their daily living is going on and has changed. And are there any neuropsychiatric or behavioral issues? It involves the usual looking through, but pretty thoroughly through their medications and their over-the-counter supplements, because many people, for years, they are get medication drift, and it's not recognized that, for example, that early sleep changes can be due to a neurodegenerative condition, and mood changes, etc. So they may be taking, Tylenol PM with Benadryl in it, with diphenhydramine, which again you can take off and really improve their cognition. You want to obviously go over the risk factors, including exercise, sleep, nutrition, alcohol. People who have impairments sometimes will drink and they'll forget they drank how much. Ask obviously elements of social and family history, and ultimately use one standardized kind of assessment tool that's validated, including your exam, to decide, based on all this information that you've gathered, is there something wrong or potentially can be wrong? How confident are you that you can really truly say this is normal aging? If not, what do you do next? And what are the steps there? Oftentimes the steps are delineate what's wrong, what the pattern, what cognitive domains or other things are affected, and that's going to give you a clue about also where to go next with your evaluation, but also what to target for symptom management, and what to rely on and not to rely on for compensatory strategies. So ultimately, you have to integrate all this data into diagnostic formulation. And the first step, as I mentioned, is you have to decide, is something potentially wrong and how much? Could you really say they're cognitively unimpaired? Would you say, oh, this is just subjective? But even subjective is actually a risk state. We know that. Is this actually at the level of MCI, mild cognitive impairment, or is this really mild dementia or beyond, where there are some elements of independence that have now been kind of forsaken to a certain degree? So the pattern of what's abnormal, the syndrome and what's wrong also helps. And in some cases, it could be memory. In some cases, it could be language. In some cases, it could be actually have elements of motor sensory dysfunction, along with some aspects of cognition. It could be behavior and executive function. And all those can tell you, in some ways, point to you what may be primarily leading candidate for cause and what other things could be contributing. Because just because they they may have Alzheimer's, it doesn't mean that they're not drinking too much and they're not a victim of polypharmacy, or they may not have sleep apnea and mood disorders. This is the care. This is the Northwestern Care Pathway that talks about different symptoms. And again, we think about memory as being the major one, but that may become really manifest early to some people because they've heard about it, because people are forgetting their appointments, or they're misplacing items all the time, or repeating the same questions. But language is also very can be affected early in a lot of people, sort of having word finding difficulties, having more difficulty spelling or reading, comprehension difficulties, etc. Visuospatial dysfunction becomes really, really important also for driving and other things, but people not seeing things that are right in front of them, not being able to judge distances, and that is another system that can be involved relatively early in some. Emotion and behavior, so sort of poor judgment, social disinhibition, difficulties with empathy, etc., shouldn't be put down to the person sort of becoming eccentric. And the big one, I think, also is the executive part that overlaps a lot of times with sort of behavior, which is the inability or difficulty with planning, organizing, multitasking, making goal-directed decisions, completing tasks, being easily distracted, and being less mentally efficient, and things taking them much more mental effort to complete. So these are the different sort of symptoms that can point to the different domains that can be involved. Um, uh, Again, don't you can come back to the slide if you like, but the idea is you can probe each domain in your own way and however you're proficient. I'll show you some instruments, as you know, things like the MoCA, MMSE, and SLUMS, etc. But there are things that are available that if you want, you can have um, your patient and their care partner complete before the visit, send it home with them to look at, that you can score about how things may have changed in their activity daily living. Are they doing it, but not as well as before? Do they need a little bit of support? Do they have they given it up? And these can all be quantified, including also changes in neuropsychiatric function, mood, anxiety, um, you know, um, being uh, a bit disinhibited, hallucinations, delusions, things like that. So as far as the brief office screening visits, we know the MMSC, that, the MoCA, St. Louis memory mental status examination, mini-cog. One of the major things to know about this is, each one has its strengths and limitations. Um, and most of them will take about 8 to 10 minutes or so. I really like the MoCA. It's really accessible in multiple languages, as I'll show you, and it's a bit more sensitive really to the earlier stages. But one of the major points of takeaways is that you have to interpret scores not just as a cutoff really, but in the context of the person. So for the MoCA, as I mentioned, it's scored out of 30, as you know, and the general cutoff for you thinking, maybe something's going on is less than 26. You add a point if their education is lower, is high school or less. There are multiple versions in different languages, and you can also do the visual impaired version out of 22 that really skips these parts. One part I want to have you pay attention to is the part relating to the memory. So you ask the questions here, for example, face, velvet, church, daisy, red, and you see if they can encode it. Later on, you ask them to recall it, and if they don't, you score it. But keep going and give the category cues and the multiple choice cues, because that gives you actually the memory index. And so what happens, for example, so let's say you say to them, what was it? And they give you some answers, but they don't remember the, for example, the flower. So you would category cue them with, well, it's a type of flower. And the next time, if they don't get that, then you give them multiple choice, okay? And you may say, well, it was a rose, daisy, or a tulip. So the way you score that is you actually give them a point. You give them 3 points, fully 3 points, for if they recall each one of them. You give them 2 points if they get it with a cued recall. You give them 1 point if they get it with multiple choice. You don't give them any. If even with the multiple choice, they choose the wrong one. So you can see now you've expanded something that you score out of 5 here into something that has a range of 0 to 15. And that's really useful. And it turns out that there are other indices for the MoCA. So if you wanted to have a little mini domain breakdown for yourself, you could put this in a Excel file like I've done and add up a memory index, an executive index, a visual spatial index, a language index, an attention index, and an orientation index. Of course, they overlap a little bit as many tests do and domains do. But remember, there's not just one test. Here are the pros and cons of many different kinds. So here's the MoCA, MMSC, MiniCog, for example. MiniCog is good, except for it's just, it's very, very quick and a little bit less sensitive, for example, in some cases. And there's other forms, including longer forms that some specialists may do and may take up to 20 minutes or so. Again, it's up to your proficiency what you like, but I would say MoCA is a good one. If you're not sure, and I would really encourage you to think about neuropsychological evaluation. If you have a good neuropsychologist that you can work with that really is interested in neurodegenerative conditions, particularly when the evaluation is borderline, or if the individuals have an unusual clinical profile, like if they have low or high education, for example, to clarify really patterns of impairment and strength, to track them, to look at the effect of mood, and certainly competency is one thing. But neuropsychology evaluation can really help with determination of ability, disability, their patterns of weaknesses and strengths, to suggest even further workup, and for safety recommendations and compensatory recommendations, really, really important. I'm not going to belabor this, but as I mentioned too, there's the different syndromes can be anything from an amnestic syndrome with difficulty with learning new information that oftentimes will map to AD, or maybe mixed AD and vascular, or maybe TDP-43, to aphasic variants, which sometimes can be AD depending on the kind, but oftentimes are related to frontotemporal dementias, lobar degenerations, or visual spatial syndromes that may be due to AD, but also to Lewy body, or progressive behavioral variants that sometimes are AD, sometimes are related to frontotemporal lobar degenerations. And then the ones that actually involve some elements of cognition along with motor function could be because of Lewy body disease or other cousins. So what do you do? When you are trying to now rule in or rule out cause, you do both now. So what you do is you send some labs. These labs are going to tell you if there's something wrong that's generally common in some older people, but having thyroid be off or B12 be off, and you fix that, even an individual with Alzheimer's disease, that could actually improve their cognition. Sometimes we'll send CRP and ESR for inflammatory conditions, infections, or cancers. The recommendation is to do one structural imaging. MRI is preferable, absolutely preferable, and it's a standard of care, because we want to see not just the pattern of neurodegeneration, but also the vascular components that we can look at. MRI is much, much better at looking at atrophy patterns, particularly in the mediotemporal lobe. Here, for example, you can see the ventricles have become a bit larger here, and there's atrophy in the mediotemporal lobes. But also in FLAIR images, you can see the degree of white matter changes. Or they may have microhemorrhages, which is going to change your management to be very, very cautious about giving them anticoagulation. And about 15 to 20% of individuals with Alzheimer's disease, even in the beginning, have microhemorrhages. So you have to be very, very careful to anticoagulate them. And these are seen on, again, this is just hemosiderin left over. This is not fresh blood. So MRI is really important. Just be aware of the fact that the read may come back age-appropriate white matter changes in atrophy. Unfortunately, many of our colleagues really undercall the amount of white matter change, and particularly atrophy patterns in Alzheimer's disease. And just because somebody doesn't have mediotemporal hippocampal atrophy, it is impossible for a radiologist to say, oh, no Alzheimer's disease. Well, they may not have that variant, and which is very, very common. So they may not have degeneration in the mediotemporal lobe. So if you see it, it's the positive predictive value is good. If you don't see it, the negative predictive value is less. Other ways of seeing neurodegeneration are getting an FDG PET scan. Medicare pays for that, and people you're considering having frontal lobe changes. But honestly, this is not necessary for the vast, vast majority of people. And the pattern that you would get is generally bitemporal and parietal or temporoparietal hypometabolism. If you want to look at actually evidence for AD-related neuropathological changes, so the A and the T and the N, as I mentioned to you, it's spinal fluid, amyloid PET, and tau PET. Amyloid and tau PET are approved and available. It's just that they're not covered outside really some places, by insurance. Really, the VA is pretty much the only place that covers this. Spinal fluid would be covered, actually, both the LP and the analysis now through Medicare mechanisms. And this is something that specialists do a lot. Now, occasionally we will do other things like sleep studies and EEGs and other things, but my point to you is that this should be very rarely, this should not be on auto sort of order. Because if people are coming back to get some of these things ordered at this level, they must have a really atypical syndrome or maybe rapidly progressive syndrome. CSF profile will come back oftentimes with consistent or not consistent. So if you get a really nice low A beta 42, which means it's sequestered up here. So if you measure it in the spinal fluid, it's actually lower, and you get high phospho-tau, you get something in this quadrant. But occasionally, you have to make allowance for the fact that these are, again, measurements that have error in them, and test-retest reliability and sample processing can also affect that. So in some individuals, you can get a score here that you may say, oh, well, it didn't fall nice here. It doesn't mean they don't have AD. So, if it's right there, that's a different story. And what do they look like? So when I say these amyloid scans, generally they look like 50 shades of gray. So they come back kind of looking like this. This is a negative amyloid scan. And what happens here is the tracer gets actually taken up in the white matter. So you get this really nice pattern of just basically white matter binding. But if you get basically cortical binding, where this pattern changes, and you see this is no longer distinct, kind of like the tree with leaves on it, that's an amyloid, that's a positive scan. Again, that's read as positive or negative in a binary way. There's also ways to look at it quantitatively. But basically, if there's plaques in the cortex, you will lose this gray-white differentiation. All right, so dementia and cognitive aging researchers, School for the Gifted, what are we going to do? The biomarkers are going to help us, I think, in the future. And I'm not going to belabor this, just to tell you that spinal fluid is probably still really our go-to right now. But ultimately, blood is coming down the pike and needs to be validated in the clinical setting. Even though there are a few things available, they have not been really validated fully in the clinical populations. And things like amyloid PET and tau PET are available, but need to be reimbursed better. But we can still see things like patterns of neurodegeneration through MRI, and some specialists would also order things like FDG PET in some places. And really, emerging biomarkers are going to be looking at neuroinflammation and other types of ADRD, including alpha-synuclein. All right, so in the next 5 minutes, I'm going to go through a patient case to sort of bring things together. Here's AA. He's a 64-year-old right-handed gentleman who comes in with a chief complaint of some changes at work and finds it more stressful. It turns out when you push a little bit further, he works in a very fast-paced environment. He's noticed a lot more inefficiency in his work, causing him stress and causing him to sleep less and wake early and being concerned. Wife wasn't there, but after I spoke to the wife on the phone, she says, you know what, he does seem a lot more stressed. And actually, I've noticed he's forgotten and misremembered some conversations that were really kind of frankly unusual. Occasionally he's more repetitive, and he really wasn't this way before. So after doing a structured interview, what I determined is that, you know what, for the memory, I thought that this was there were some mild changes in symptoms with repetitive misremembering. For his attention, even though he was always a little bit apparently inattentive, this has really changed, and so there was at least a moderate change. For executive functions, sort of multitasking, planning, things like that, it was sort of mild to moderate. Didn't get a big hit on language symptoms, but really with behavior, that was the other thing. It turns out that there have been some judgment interaction issues with the team at work. And his wife said that, maybe they're considering him a bit more aloof or less sensitive and more dismissive and anxious and potentially more less motivated. So when I did a review of a daily function, really some mild changes where things were more effortful than before, like with bill paying, taxes, shopping, current events, remembering appointments. He was taking, some notes more, things like that. For his behavior, it turned out that there were small changes. He was a little bit more irritable, a little bit more anxious. There's some suggestion that he may have looked a little bit sad at times, and there was some lability. And this was actually stressing his wife out in a mild way. But when I did a geriatric depression scale, this didn't show anything. And he didn't look clinically depressed either. And sensomotor review found no concerns. Additionally, as far as other risk factors, parents were alive and well. He had a concussion that was minor when he was young. He was not taking any meds for borderline hypertension, no supplements. Very, very bright person with a BS and a PhD, was married for many years, is a high-level executive, rarely drank, and was exercising more in the past, less now. And through another interview, it looks like his wife was a bit actually moderately stressed. Did the rest of the exam, was unremarkable, and did a MOCA and was 27 out of 30. So I guess I should just say, you're normal, the score is a normal score, and we don't need to do anything more. Okay, you know that's not true. Because actually, you have to, again, put this in the context of the person. It turns out they actually, when I did the MOCA, missed 3 on recall. So, here's some complaints about memory and some other changes. And actually, even though the score is quote unquote above 26, really he missed 3 on recall, which is concerning. Encoded well, and on the memory index scale, actually got 7 out of 15. So what happened is that, remember, he got a few right away, but then needed some help. So some additional testing suggested that his fluency was decent, although the fluency for animals versus letters there was a discrepancy there, and this is dementia or Alzheimer's 202 as opposed to or 201 as opposed to 101. But if generally you ask people to give you words starting with a particular letter like F, no conjugating stems or proper nouns, and if their first word out of their mouth starting with the F word, and some of you are chuckling now, is something that's not appropriate to say, that tells you something about their impulse inhibition. But generally, if they can generate, if they're in their 70s and 80s, can generate 10, 15, 20 words, that's quite good still. And if there's a difference between the number of animals that can generate over 60 seconds versus F words, that may suggest that there's a little bit more stress here in the medial temporal lobes networks here than in the frontal lobes, and that was the case with him. The other things really didn't show much, and actually he didn't seem depressed. And this was a good case for referral for neuropsychological evaluation. I actually brought this up because there was difficulty convincing him at that point that there was anything that's up. And neuropsych evaluation really pushed him harder. And in the context of estimated superior to very superior premorbid intelligence, he had variability of scores. Many of the scores were still superior, but he actually had some mild impairments in verbal and visual memory, and some aspects, not all, of executive functions were borderline. And when I say impairments, remember that you have to fall a lot for someone like that to score in the 5th percentile, 7th percentile, 10th percentile. Somebody like him who was scoring mostly in the 90th, 95th, 99th percentile. So his lab panel didn't show anything. His MRI was actually read as a normal atrophy, but to my eye was anything but. He actually had hippocampal atrophy, medial lateral temporal atrophy, and subtle frontal atrophy. And were able to get biomarkers for him. And he was amyloid positive, tau positive, and actually neurodegenerative and N positive. Um, and so in his case, he's still functioning, but he has objective issues. So this is MCI due to confirmed AD. And he went on to start standard treatment for Alzheimer's disease and ended up actually going into a clinical trial. All right, Mr. Osborne, maybe excuse my brain is full, so small brain. And so in summary, I think what I could sum up to say is that we understand misfolded proteins are the cause of Alzheimer's disease and have many downstream effects that are very complex. And we've been able to now separate the pathobiological stages from the clinical stages. That timely and accurate and appropriate detection and diagnosis, communication and disclosure is really, really important. And this has to be individualized, particularly early. And the process takes time, but and some expertise and proficiency. But people really appreciate it. And if we put them in the path, and if to make the right decisions for them, this is something that's really valued by our patients and their families. And one of the take homes is that we don't wait. We shouldn't wait until there's brain failure and irreversible loss of brain cells and destruction of synapses and cognitive networks in order to do something. In all the other diseases, we don't do that. And the data shows that delaying just the dementia clinical stages of Alzheimer's disease by 5 years would reduce Medicare costs by about 50%. And we don't wait in other conditions. We don't wait for cancer, stroke, heart disease. We don't say, hey, let's just wait. Oh, you have a little, maybe a growth here. Let's wait until it metastasizes, until we look for it, accurately diagnose it, or treat it. We don't wait for osteoporosis for people to have spinal fractures everywhere. We try to take a proactive approach. And this is where we are with Alzheimer's disease. And we need to learn to do this proactively in AD. Biomarkers will allow us to do that. They're coming. We already have spinal fluid, and some specialists have access to PET scans, but blood will be coming, and ultimately we'll learn, we're using the biomarkers, how to stage people better. So just like oncology will have more precision. We don't just say, like breast cancer, right? On TV, you see, they say, well, if you were ER positive, HER2 negative, node positive, then you go into these treatments. And this is where AD will be going, the field will be going. As we use these biomarkers, people show up with symptoms. It may be due to multiple different things. And with the biomarkers, we'll be able to say, what's causing and what's contributing. So we'll know biomarkers of trait and state and effect and hopefully target engagement. This is not tomorrow. This is in the next 1 to 2 or more decades. But you'll need to know more about it, because actually they'll be coming to clinic also. And as far as treatments go, as we know, most of the treatments that we have now are deal with symptoms, and they will put people, for example, on a higher path. But treatments are coming down the pike that are looking at the underlying pathophysiology, and particularly in removing amyloid from the brain. And with them, really, the idea isn't to give them the symptomatic bump, but the idea is to add that to the already medicines that we give in the multifactorial care that they give, to actually slow down the disease process and delay the last stages, the middle to last stages of the disease for as long as possible. And that's something that again, will be coming down the pike. A cure to reverse things when people already have brain failures many decades away. But ultimately, our therapeutic strategies, and I haven't gone into lifestyle interventions as much, although we touched on them, is now to have combination therapies, ultimately add disease-modifying therapies as they're coming to clinic more, and then prevent in the future. And ultimately, I think there is a lot of hope, and the journey has already begun, and that the glass is more than half full. And as my license plates say in different places, ultimately for our children and our grandchildren, I think we will be able to cure this disease. But in the next few decades, I think we'll be able to to do better job of diagnostic and management and changing the trajectory. And we can do this together. And so I appreciate your attention for this and for taking care of patients and families with these conditions.